സാറ് ജോയിൻ ചെയ്താ?
ജോയിൻ ചെയ്തു. സമയമായില്ലല്ലോ. വെയിറ്റിംഗ് ഫോർ ദ only 2 more minutes to.
സുഖം തന്നെയല്ലേ?
സുഖമായിരിക്കുന്നു സാർ, സുഖമായിരിക്കുന്നു.
Hello.
Hello.
Yes, sir. So you can start whenever you want.
Hello.
So you can start whenever you are ready.
Okay. I think your voice is breaking. I don't know if it's a problem.
Yes, sir. Yes, sir. Yes, sir.
Am I audible to you clearly? Am I audible to you?
Yes, sir. You're audible.
Okay. Fine. Thanks.
Good evening, sir.
Good evening, Umar. Good evening.
Congratulations, sir. Congratulations.
Thank you.
Sir, കാണാനല്ല വരുമ്പോ മീറ്റ് ചെയ്യാം നമുക്ക് സാർ വരുമ്പോഴേ.
Oh, sure. Umar.
Okay.
Okay, shall we start?
Yes.
Okay, right. We'll start. My screen visible to you and audible?
Yes, sir. The screen is visible and.
Right. So, as usual, we start with a short case. It's not that too short still. It's a story of a 76-year-old diabetic man. In fact, this patient was admitted in the surgical ward for septic arthritis of the left knee 3 weeks back, for which surgery was done 5 days later. However, for the last 3 days, he noticed pain over both upper limbs, followed by weakness of both upper limbs. No paresthesia or any weakness of any legs. So short history, noticed pain in both upper limbs, followed by weakness of both upper limbs. So this examination finding, scales are all normal. With facility of both upper limb, or was generally 8.1 to 2. Only because normal power. Only this was surgery was done. All reflexes perhaps.
കാലം മടക്കിയിട്ട് അങ്ങനെ ഇരിക്കട്ടെ, അങ്ങനെ ഇരിക്കട്ടെ.
Couldn't do it because of the handling around the neck. And there was
ഈ കുട്ടികൾക്ക് അറിയാമോ? ഈ കുട്ടികൾ അറിയുന്നുണ്ടായിരുന്നു. ധൈര്യമുണ്ടല്ലോ. ഇതോ ഇതോ ഇതൊക്കെയോ ഇതൊക്കെ ഉണ്ട്. ഇതോ ഇത് ഇത് ഇതൊക്കെ അറിയാം. ഞാൻ ഈ കുത്തുന്നതും ഇത് ഒരേപോലെയാണ്. ഇവിടെ അറിയാമല്ല, ഈ രണ്ടും ഒരേപോലെ തോന്നുന്നുണ്ടാവും. ചിലരും തോന്നുന്നുണ്ടാവും. ഇതുവാ ആ ഒരു വിരയിലുണ്ട്. ആ വിരയിൽ ഇപ്പോൾ ഉണ്ടാവും. ഇപ്പോൾ ഉണ്ടല്ലോ. ഇപ്പോഴോ
joints are all normal.
ഈ കാലിലും പറയണേ.
It is embedded on both.
ഇപ്പോഴോ ഇപ്പോഴേ ഞാനാക്കാം. ഇപ്പം എങ്ങനെയാ? മുകളിലോട്ട്. ഇപ്പോഴേ മുകളിലോട്ടല്ലേ? ഈ തൂക്കുന്നത് ഇതുപോലെ അറിയാം. ഇതിന് വ്യത്യാസം ഉണ്ടെങ്കിൽ പറയാം.
There is no sensory level of anything in the plane. So summarizing the findings, LF examination were normal. Motor system, tone hypotonia of both upper limbs. Power, weakness of all the muscles of both upper limbs, about 8 to 2. Power of the right lower limb grossly normal. Detail all absent, both upper limbs and right lower limb. Sensory system, touch pain normal in both upper and lower limb. Vibration normal in the upper limbs and lower limbs. AP sensation was impaired over the toes, normal in the upper limbs. So these are the findings. So where is your localization and what is the likely diagnosis?
Element syndrome, sir. Element syndrome. Since there is no definitive evidence.
Yeah, correct. Just 1 minute.
Yes, sir.
Tell me, Umar, once again. Element syndrome.
This looks like an element syndrome because there is no spasticity or upgoing plantus or any sensory level. So he has peripheral neuropathy as well as possible plexopathy in both upper limbs.
Okay, good. That's something we have to keep in mind. Anything else? Any other possibility you want to keep in mind? Okay, any other possibility from anyone else?
Cervical radiculopathy.
Radiculopathy due to, it's extensive involvement from C5 to D1. Both are all muscles, the upper limbs are affected. No sensory findings in this patient.
The metabolic like hypokalemia.
But that is little odd because it's contained to upper limb and the pain in the upper limb. Lower limb power was normal.
But reflex are absent.
Sir, any pain also?
Pardon?
Pain.
The pain in the upper limbs followed by weakness. Reflexia could be also diabetic.
Epidural hematoma with spinal shock.
Okay, that's a good possibility, right?
Bibrachial plexopathy in diabetic.
But we can call a spinal shock because the lower limb power is normal. This is spinal shock. It was difficult to explain the normal lower limb power. And the sensations are also normal. Except the GPS sensation over the dose. Bindu, what did you say?
Bibrachial plexopathy, though rare, but immune-mediated in poorly controlled diabetes.
Right, that's a possibility. Okay, so possibilities as Umar and bilateral brachial can be developing GBS also. Possible.
But the pain is too old for a Gillan medicine. That too confined the upper limb. So the other possibility could that be because the septic arteritis, some septic embolia has gone to the cervical cord, the middle part of the cervical cord, causing bibrachial weakness.
But the problem is the LM, as you already said, is LM paralysis. There is something such a cord lesion here. Okay, what test do you need now?
Nerve conduction study, including plexus.
Okay, no conduction study. This is the conduction study. The motor conduction, the ulnar potential is amplitude is low, but not totally absent. And in the lower limb, the peroneal amplitude is decreased. Tibial amplitude is also decreased. Peroneal is affected on the right side also. So remember, there is also the diabetic also. And FAV latency is normal. Sensory potential are all normal.
So porphyria can involve only upper limb.
Very odd age group for porphyria, because it can affect again it's not against the possibility. But age group is very odd.
So we have to think of a route, multiple route involved. Sir.
Very good.
Multiple route.
Multiple route or segment.
Motor routes, multiple motor routes involved.
That's the thing you have to logically think. But sometimes no hematrophy need not have any sensory potential, sensory potential. That's also very motor. But extensive involvement of both upper and lower limbs is all muscles are affected, is permanent hematrophy. Extensive radiculopathy is a possibility. Again, all routes affected, less likely.
Anterior Simpson.
That's about, if you look at the nerve conduction study, there is a possibility. Because he has got a sensory potential is normal. Lesion is preganglionic. That means in the roots or maybe in the anterior muscles.
Sir, is the nerve conduction done in the first week of onset of weakness?
No. It was done after 10 days.
Any conduction blocks, sir?
No conduction block. No conduction. Only axonopathy.
Sir, is there any fasciculation or any denervation changes?
No. We did not do any EMG in this patient.
Any muscle, any tenderness of the muscles, sir?
No tenderness. No tenderness. Acid weak.
CPK also. CPK also normal, sir.
CPK was not done. So what are the investigations you like to do?
MRI, sir.
Okay. So
MRI of the plexus.
MRI of the plexus. But we demonstrated the spine was done. This is the lateral view. This is the T1 weighted sequence. This is the T2. So what do you think the possibility is?
Some epidural hyperintensity seen, sir.
Where?
C1 to C2.
There is a pre-vertebral hyperintensity, sir.
Okay, very good.
C1 to C2.
You can see there is a pre-vertebral hyperintensity as well as the discitis also there. Because the hyperintensity, see, this is a CSF. But what is happening anterior to the CSF? This is discitis. Okay. So what else you want?
Contrast.
Contrast study, sir.
Very good. See, what do you see? Look at the contrast now.
Pre-vertebral epidural collection impinging the cord.
And that's one is pre-vertebral, the other is epidural. Both are there. Okay. I'll show that this is the pictures, axial cut. Now I'll show each one. So this is the pachymeningitis, enhanced dura and the meninges. That is the extradural abscess. And there is a spondylodiscitis. And there's a prevertebral abscess. Look at the axial cut, you can see that abscess. The surrounding, this is, as which was correctly telling, it's related to the septic arthritis. You have to keep that possibility, either hematoma or extradural abscess sometimes can present like longitudinal element finding. This you have to never forget this possibility. Because it is not compressing from outside like a horizontal compression. It's a longitudinal compression. Because abscess is called hematoma and abscess goes like that in a longitudinal fact outside the extradural space. And they can produce multiple radiculopathy as you are also suggesting. So that possibility you have to keep in mind. Morosacin multiple radiculopathy. The cause of the radiculopathy is because of the external abscess going in a longitudinal fashion. It's uncommon presentation because patient has not much touchy, not much sensory involvement is very odd. Absent sensory involvement is very odd, but still you have to keep that possibility in mind from the background of a septic arthritis. Okay. Shall I go to the next case if there is no questions?
So how was it managed, sir?
He was managed systemic antibiotics. I don't know whether surgery was also done. He was referred to neurosurgery. I do not know the follow-up of that patient. This I saw the patient on consultation. But in neurosurgery, and they must have done some surgery. Okay. Shall I go to another case now?
Yes, sir.
Okay. So this is a story of a 20, it's a long case. There is also some management problem in this case, apart from the diagnostic problem. The story of a 23-year-old woman. In fact, he was first seen by me 9 months back. Not 9 months now, now it's already 1.5 months. This is the old one. 1.5 years back. At that time, she presented with the history of diplopia on prolonged reading for 1 year. And history of occasional imbalance. Examination at that time, the extraocular movements were normal. On deepening the gaze downward, patient complained of diplopia. There was no nystagmus. She was suspected to have manifest latent skin. That's what I thought initially. Very old right superior oblique weakness. These are the two possibilities I kept. If you complained of intermittent diplopia after reading for the last 1 year. Examiner did not reveal any object in neurology. So I taught an urgent exercise asked to come for fault. I did not do any investigation. Because epilepsy of 1 year without any findings, not that. Since her symptom did not improve and imbalance worsened, she consulted another neurologist who found out some abnormality in the examination and MRI was needed. She was given medication for 3 months after seeing MRI, which did not relieve her symptoms, and she came back again for a second opinion. So this is the second examination. After first examination, I did not make any findings. This is second examination when she came back after 3 months. And you know, she has got a non-beat nystagmus. Very obvious. You can see that on looking at the left side. Ocular movement was looking up. And as taught, I mean, as I usually taught, it is maximum looking down and down. You can see the downbeat nystagmus. Okay, right and left. You can see the nystagmus now.
കണ്ണ് മുറുക്കിയടച്ച് മുറുക്കിയടയ്ക്ക് കല്യാണി ചെയ്യുന്ന ഈ മതി മതി പാവം തുറന്ന് നമ്മളെ ആന്ന് പറഞ്ഞ് ആ മറ്റേ മറ്റേ കേട്ടില്ലേ മറ്റേ
is a normal, no finger nose incoordination. This subsequent no people owner syndrome. Extraocular movements normal.
Make it closer. ഇവിടെ നോക്കിയേ ഇവിടെ കൗണ്ട് നമ്മളിവിടെ നോക്കാം ഇവിടെ 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 ഇതിലൊരു കോട്ടൺ തരാം ഇതിലൊരു കോട്ടൺ വേണേ കല്യാണിച്ച് ഇനി വാ തുറക്ക് ആന്ന് പറഞ്ഞ് ആ നാക്ക് നീട്ടുമ്പോൾ നാക്ക് അങ്ങോട്ടോട്ട് തള്ളിക്ക് ഇടത്തോട്ടും വലത്തോട്ടും.
When it was directly diminished, so I did not give much importance to that. But because of seeing diminished corneal lichen, possible abnormal malformation. Mild finger nose incoordination, power in the upper and lower limbs are all normal. DTR all normal. Normally elicited, not brisk. There was fluencer. Sensations were all normal. No limb incoordination. On mildly positive, extremely positive, gait is normal, temple walking was defective. Temple walking was defective.
പെട്ടെന്ന് തിരിയണേ പെട്ടെന്ന് തിരിഞ്ഞു
Rhombus is mildly positive. That is random working. Your examination, downbeat nystagmus, extraocular movements normal, motor system normal, DTR normal, sensory normal, rhombus is normal, hand normal, tender walking effective. So where is your localization? What are the possibilities you keep in mind?
CV junction and all.
Yeah, there is one possibility which can. Someday nystagmus may vaccinate. Sometimes it may not be elicitable, sometimes it may be elicitable. So that's a possibility I also kept as a one of the strong possibility. Okay, any other possibilities anyone will give?
Multiple sclerosis, plaque, demyelination.
Right, demyelinating disease. These are the two possibilities. Anything else?
There's positive foci lesions like middle lesion involve the cerebellum, sir.
Yeah, usually Downby nystagmus due to lesions of the copies. Can also occur due to lesions inside the brainstem, but usual site is populous. But it need not necessarily be due to structural lesion. It can also be due to metabolic abnormality, toxic conditions, pet deficiency, infections. It cannot cause that thing. The site lesion is that. Okay, that's crown abnormality. Lesion tumors can again also produce that possibility. Agree. So, what investigation you want?
Autoimmune also has to be kept.
Elaborate.
Right, or it's also a possibility. So, did an MRI. This is the MRI which the patient got. There is no unknown cherry malformation. So, looking very closely, I thought that lateral sinus was slightly bulged out. Normally, it is appearance should be concave or normal. It's slightly convex. This is the player sequence. Count. Coronal cut. Then I did a contrast also. This is a diffusion weighted sequence. This is the contrast scan. There was no mass, no unknown chain malformation. The only abnormality I thought was this sinus was slightly bulged out, otherwise it's normal. Which the radiologist said maybe a normal variation. It did not give much importance to that thing. So again, came back to square one. I did not know what it is. So what do you want to do now? This interesting case.
Contrast MR venogram, sir.
MR venogram, seeing that dilated this thing, I did a venogram, but that was normal. There's no block or anything.
Paraneoplastic antibodies, 3 ANA profile,
Yes, sir.
acetylcholine receptor antibody.
Why acetylcholine receptor antibody?
When I had similar patient where it turned out to be positive, but that was mildly positive, and ultimately there was ANA profile showing SSA and ANA positivity.
So this is the cervical spine was done. That's also known. I'll show the full picture because I wanted to. The cost was not very this time. There's nothing abnormal.
This one.
I did a flexion film also to find out any abnormality in this craniovertebral junction. But the thing is, it's episodic because I'm very sure when I saw the first time, there was no nystagmus. Because I would have missed that Downby nystagmus. I thought it's a manifest latent skin deletion. But second visit, it is there clearly. And this is the cervical.
Sir, any family history in this case, sir?
No family history. That will come that later also. I'll show that later.
CSF study.
Pardon?
CSF study.
CSF was not.
Sir, what are the possibility of episodic ataxia, sir? Syndrome.
Yeah, that's a possibility, strong possibility you have to keep. Let us see this.
Anti-GAD antibody.
Yeah, which you are taking one autoimmune problem is very strong, but they do not produce something like an episodic Downby nystagmus, episodic attacks, head-like presentation. But still, that possibility has to be kept in mind. I did the routine ANA propellant or autoimmune anti-GARD I did not do.
So is it a 3 Tesla MRI?
Pardon?
Is it a 3 Tesla MRI or 1.5 Tesla MRI?
1.5 Tesla.
Sometimes small plaques can be missed in the 1.5, sir, demyelination.
Yeah, correct. Just two can be missed. So these are the, then I thought whether it could be an SCA, which can have, I've seen FCA with episodic presentation because gastrointestinal abnormalities in the SCA, they can produce episodic pattern because this is endemic to our alternating childhood and migraine. So this possibility is I can be possible in episodic attacks type 2. So serum was sent for SCA panel. This SCA panel was negative. So what do you want to do now?
Episodic attacks panel, sir?
No, that was in fact, I had another patient where the panel was sent that came as negative. So I was little reluctant because if you want to send another panel, it will cost again another 10,000 rupees for the patient. SCA panel itself cost 10,000. Little hesitant. Okay. What do you want to do now?
Any drugs there which is responsible for the nystagmus and all?
Vitamin B12.
No, vitamin B12 was, I don't know, it was, I did not do that. So I put the patient Diamox 202 in phase 2 to phase 2. And it produced not remarkable, mild. The nystagmus became less. And looking close quarters nystagmus, looking at a distance, there is no nystagmus. Looking at a close quarters nystagmus, I will show that in the next video. And taking my finger post lotus nystagmus, not sure the nystagmus happening again. Now it's coming. See, you can say don't be nystagmus now. It starts coming now. I brought the finger close to the patient. Again, now it will become very obvious. But she said she's comfortable with the Diamox, but better than this oscillopsia and the diplopia became less. With the Diamox. And the gait and the walking became long. It's just so in examination, how don't be nystagmus is much less. We're looking laterally and looking at distant object. However, it became more when it was set to object at close quarters. It was mildly defective tandem walking, but much less than before. But since the patient continued to have imbalance and oscillopsia, I thought I will try top. But there are 3 drugs which you can give for non-being nystagmus. One is Diamox, other is topiramate, other is foraminopyridine. So I thought I will try topiramate instead of Diamox. So put the patient on topiramate, which did not produce any improvement at all. Because it is slightly worse than with the Diamox. It became more. So not much benefit, slightly worse than when the patient had been on Diamox. Now, at that time, the patient gave another interesting history. She said that her oscillopsia and walking difficulty was more in the premenstrual period and becomes progressively worse just before the menses. Once the menses starts, the problem subsides dramatically. It remains better during the first half of the menstrual cycle. Then slowly it becomes worse and worse and become worse towards the end of the second half of the menstrual. This story she gave, I don't know what to make out of it. I have not seen a case, essentially literature to find out. The episodic attacks are worsening related to the menstrual period. I did not get anything, any reference or any this thing. So what will you do now? She's slightly better than monks, but not fully. The problem did not benefit her.
Sir, could this be some sort of a migrainous phenomenon?
Yeah, there is this episodic attacks at type 2 are all calcium channel abnormalities. They can be related to migraine and related to PHIV. They are all related conditions.
In neurometabolic disorders,
Neurometabolic, what metabolic disorder specifically, I don't know. There are hyperammonemia syndromes can produce episodic ataxia. There is no other findings in this patient. This is not a classical presentation. Ataxia is one. They can have other episodic vomiting, market sensorium, those things down there. And MRI also is to show some neurometabolic hyperammonemia syndromes producing at episodic ataxia. The other things, pyruvate dehydrogenase deficiency, and those conditions can also produce episodic ataxia. Apple urine disease syndrome. They all have some abnormality in the brain, MRI brain.
So gene testing with repeat MRI.
Gene test I should have done, but I told you, Vipan, already panel was sent. So I was selected to send another gene. I'm very sure that it's most likely an episodic ataxia. But the reason I'll tell you later on. I've seen cases before, before. So this is a story she's giving. What did you do now as a practicing physician? You know what I did? I stopped all the medications and asked her to send the video at the time of her maximum worsening, the premenstrual period. And she's also asked to come for a review during the premenstrual period as well as during the menses. I want to document what she's telling is correct or wrong. So the video was sent by the patient during the time of maximum worsening, that is about 4 days prior to the onset of her periods. This is the video sent by home video sent by her. Nystagmus is worse. And she did finger nose test by her because I was doing it on her. She taught her brother how to test that, and she's doing it. It is finger nose she started appearing. It was not there when I examined initially. Then see the gait now, gait of the patient. It's much more ataxic now. This is during the premenstrual period. Perfect. So she came to me 3 days prior to the menses, examining. Nystagmus is worse. Much more severe than before. The amplitude of the nystagmus is worse. It's just orthodoxy and pain uncomfortable. And also diplopia. Vertical diplopia.
ഇപ്പൊ ഒന്നോ ഇപ്പൊ രണ്ടാണ്
Skew deviation with the left eye up.
അനങ്ങിക്കൊണ്ടിരിക്കുക.
അനങ്ങിക്കൊണ്ടിരിക്കും. ഇപ്പൊ അനക്കമില്ല.
അതെ, പക്ഷെ രണ്ടായിട്ടാണ്.
രണ്ടോ?
രണ്ട് തന്നെയാ.
ഇപ്പോഴും രണ്ടാണോ? രണ്ട് തന്നെ.
ഇപ്പൊ അനങ്ങിക്കൊണ്ടിരിക്കുക.
ഇപ്പൊ രണ്ടായിട്ട്
double
കാണുന്നു.
also.
ഇപ്പോഴും
ഇപ്പൊ ഒന്ന്.
ഇപ്പോഴും
ഇപ്പൊ
See, the left eye is up compared to the right eye.
ഇല്ല,
ഇല്ല. ഇപ്പൊ
മുകളിലും താഴെയായിട്ടാ.
ആണോ? ഇപ്പോഴും മോളിലും താഴെയായിട്ടാണ് അല്ലേ?
അതെ.
So the gate is also having
കണ്ണു തുറന്നു. ഇനി കണ്ണടച്ച്. ശരി, ഒരു കാലിന് മുമ്പിൽ കാല് വെച്ച് നടന്നു നമ്മളെ. നോക്കട്ടെ, ആ വരയെ കൂടെ നമുക്ക് നടന്നു.
Okay, she's really attacking. So downbeat stamina is worsened. In addition, patient started coming a vertical diplopia even on looking up. Late ataxia is worsened. She was asked to come during her menstrual period. She said at that time the disability is much less. This is at the time of menstrual. This is there but much less. Still there, but less than what you want to the menstrual period.
വലുതായിട്ടില്ല ഡോക്ടർ, ചെറുത്.
മെൻസസ് തുടങ്ങി എത്ര ദിവസമായി ഇപ്പൊ?
5.
Menstrual diplopia this time. This is the date. This
പെട്ടെന്ന് തിരിഞ്ഞു.
almost normally without any ataxia.
ഈ കൊച്ചു സ്പീഡ് നടന്നു. നീ തിരിച്ചു അവിടെ നിൽക്കി.
It's not patient off medication.
നേരം നോക്ക്, എന്നെ നോക്ക്, കണ്ണടച്ച്.
Complex is negative.
ശരി, ഇനി ഒരു കാലിന് മുമ്പ് കഴിച്ച് നടന്നോ.
And the walking was normal. So this time was improved. No diplopia, no synapse, no ataxia. Now what will you do now? So it's document what she's telling you is correct. So what will you do now?
Some form of vertebral basilar insufficiency, like migraine, say basilar migraine.
Yeah, it could be kind of a migraine, but it's clearly related to the menstrual period. And that will say this in every cycle. Unlike migraine, this is every cycle because during the periods it becomes absent. Then in the first half it is not there. And gradually it becomes worse and worse towards the and maximum just before the period. So that means definitely related to some hormonal changes. Now during the premenstrual cycle, the progestational milk, that is when the progesterone is becoming more. That is the time when ataxia is more in progress. Obviously, it's related to some channelopathy only, which has got some hormonal influence. That is there. We cannot prove it that what is a basic pattern. There's no literature support to find out that such a condition. It confirms such a condition. So you have to manage on your own. You have got a patient in front of you with this condition. What are you doing? You know what
Sir, we can do one more test, like the episode ataxia panel also, sir. In addition, so then.
Yeah, that we could do. That can confirm it. But again, I'm sure about the episodic ataxia now. But what is the patient? That's it. So I started the old Femilon. You know what is Femilon? I did not know. So I asked the gynecologist, I want some drug which can suppress this hormonal changes during the premenstrual period. This is it's an oral contraceptive drug, which you give for 21 days starting from the second day of the menses for next 21 days. So this is Femilon tablet. It's an oral hormonal combination of the drug containing desogestrel and ethinyl estradiol. It's a combination of progesterone and estrogen. It's commonly used for diagnosis of female and other polygamia. Anyway, so she was put her on Femilon and 20 days after putting on QC or contraceptive drugs. This time must be still there, but much less. According to her, she's felt maximum better with this drug. hardly any nystagmus. It is there. And there is no attacks.
ഇനി കണ്ണടച്ചോ?
Compass is negative.
ഇനി മോള് നടന്നു മുമ്പോട്ട് പോവാ. സാറ് നടക്കുന്നവരാണൊക്കെ. ഇനി തിരിച്ചു നടന്നു. തിരിച്ചു വന്നേ, നടന്നേ.
Patients improved. So according to her, the improvement is much better than that due to the diagnosis. But still, she has got a causal upset to some extent. So what to do next? So I thought I will put the patient dalfampyridine, that is 4-aminopyridine, 10 milligram BD. So 4 weeks after starting dalfampyridine, there was no improvement. Nystagmus worsened.
ഇവിടെ
There is ataxia. There is compulsive positive. 4-aminopyridine did not do any benefit for the patient. So no improvement alpha 4-aminopyridine. So what will you do now? As a practicing physician, she said she's going to her husband next week, next month. So if she must, you decide what treatment I should take.
Any role for sodium channel blockers like the carbamazepine?
No, that I did not try because that is not given as a drug for episodic attacks have not been diagnosed.
So what is 4-aminopyridine available as?
And this Dalstep, dalfampyridine, which with the drug we give for gait problems in advanced Parkinson's disease and multiple sclerosis patients with gait problem. This drug is given.
You said Dalstep that we use for
Dalstep, yeah, Dalstep. That's dalfampyridine, yeah.
Is it 4-aminopyridine, sir?
That's 4-aminopyridine. It's amlopyridine, it's 4 or not, I'm not very sure, but it is dalfampyridine. So now what to do now? That's the question. Now we, as a practicing physician, we come across kind of problems. There's no literature support, but this history is very clear cut. We have documented the history that it is worsening during the emergency. So you know what I asked her, which of the drug among the many tried benefited the best? I wanted her choice. Is it Diamox, it is Feminone, or something like that. She said Feminone. I sent her on that because she said this is much better than that what she felt with the Diamox. So I sent her on that drug with advice to take during the second half of the menstrual cycle. She asked me whether I did correct or wrong, I do not know, but this I told her. And I told her about the problem of becoming pregnant. She said, anyway, I'm not planning pregnancy for 2 years. I will take for 2 years and come back to India. That's the story of this patient. So I'll show you one more case. This will give, add credence to this previous story. This 14-year-old boy came with this type of imbalance while walking for 2 days. No other complaint. This patient used to get such episodes lasting for 1 to 4 days for the last 1 year. So this is a very clear-cut history. Duration may vary from 1 day to 3 days. So this is at the time of attack. Not so good, classically not being nystagmus.
ഇവിടെ താഴെ നോക്ക്. ഓക്കെ, ഇവിടെ നോക്ക്. ഇവിടെ നോക്ക് മോനെ. ഇവിടെ നോക്ക്. കണ്ണ് മുറുക്കി അടിച്ച മോനെ, പല്ലി അണിച്ച് താമസിക്കുന്നതെന്ന് പറഞ്ഞ മോനെ.
Yes, it's got mind dysarthria, but not very gross.
പിടിച്ചോ.
Water power was normal.
മോനെ കൈ പൊക്കി. എൻ്റെ വിരലിൽ തൊട്ടെ, മൂക്കി തൊട്ടെ, എൻ്റെ വിരലിൽ തൊട്ടെ.
Very minimal incoordination of the upper limb, but gait was attached.
മൂക്കി തൊട്ടെ, എൻ്റെ വിരലിൽ തൊട്ടെ. ശരി, മോനിക്കട.
Reflexes are all normal and through the sensations normal.
മുമ്പോട്ട് നടന്നു വാ.
Just got ataxia. And walking was also.
ശരി നീ മോൻ തിരിഞ്ഞ നടന്ന് നടന്നു പേച്ച് പോകാൻ എനിക്കറിയാം എന്താ നടന്ന് നടന്ന് നടക്ക് നടന്നു നടന്നു നടക്ക്.
So this patient, I was very definitely it's ataxia. So exam did not be nystagmus, no dysarthria, minimal nose information, severe impairment in tandem walking. Again, the MRI was taken at that time. It was normal. So we thought episodic ataxia type 2. Patient was put on Diamox 250 milligram BD. We subsequently increased to 2 BD. No further episodes even after 4 years on Diamox. That confirms that's like episodic ataxia. So review after 5 months on this thing.
ഇവിടെ നോക്കി
No nystagmus.
ഡയമോസ് കഴിഞ്ഞിട്ട് എത്ര നാളെ രണ്ട് തിരിച്ചു വാ.
It is normal.
ഇനി അന്നാൾ നടന്ന പോലെ ഒരു കാര്യം മുമ്പേ കാണിച്ചാൽ മതി.
Endomark is also normal.
ഇനി തിരിച്ചു വരാൻ തിരിച്ചു
This patient, I did the genetic test because I was sure about it, but still, so this, the result is that no pathogenic or likely pathogenic variants possibly was reported phenotype is genetic. So I do not know. This is a clear-cut case of episodic ataxia type 2. It is episodic, responding very well to Diamox. There is no myoclonus, neuromyotony in between. So it's a clear episodic ataxia, but still the genetic test was negative. So this is the thing I had in mind. That did not I asked for the previous lady genetic test. I thought it may someday fruitful. That is the same. This boy, let us see the course of illness, what is happening here. The patient is put on Diamox 2 milligram, 2 tablets twice daily for 1 year. No further attack. Dose was reduced to 101 after 1 year. And remained asymptomatic for next 9 months. Presently, in January 2022, following a fever, recurrent vertigo and vomiting, for conditions for 2 days, and he came to me at that time. This is while on Diamox 101, the fever.
ഇവിടെ നോക്കുമ്പോനെ
This time has become gross, but
കൊച്ചിനടുത്ത് വെച്ചു ഇവിടെ ഇവിടെ മോനെ ഇവിടെ നോക്കിക്കേ പല്ല് നോക്കണേ മുകളിൽ നോക്കുമ്പോനെ ഇവിടെ ഇവിടെ ശരി കണ്ണ് മുറുക്കി അടക്കി പല്ല് കാണിച്ച് ഈ നാക്ക് നീട്ട്
ഞാൻ തിരുവനന്തപുരത്താണ് താമസിക്കുന്നത്.
ഓക്കെ ഇതിന് മുറുക്കി പിടിച്ച മോനെ മുറുക്കി പിടി വിട്ടെ കൈലിങ്ങനെ പൊക്കിക്കേ മോനെ എൻ്റെ വിരലിൽ തൊട്ട്
he developed incoordination of the upper lip.
ഇവിടെ തൊട്ടെ
As well as severe ataxia.
ഈ കൈണ്ട് ചെയ്ത് മോൻ കറക്റ്റായിട്ട് തൊട്ടെ ഈ കൈ കൊണ്ട് ചെയ്ത് ശരി മോൻ കിടന്നേക്ക്
Motor for everything was normal.
താഴെ മുട്ടിക്കണം ഇനി
He still became test became not normal.
ചെയ്ത് കുറച്ചോണ്ടോ താഴെ മുട്ടിക്ക് ഒന്നുകൂടെ ചെയ്താൽ മതി അതേപോലെ മറ്റേ കാലം കൊണ്ട് ചെയ്ത് താഴെ മുട്ടിച്ച് ഇനി ഒന്ന് വെച്ചോണ്ടോ
This is the need of the patient.
കേട്ടോ കാല് ചേർത്ത്
He needed 2% support to walk.
കൈ വിട്ട് നോക്കട്ടെ മുമ്പോട്ട് പോകുമ്പോൾ മുമ്പോട്ട് വാ കാല് ചേർത്ത് വെച്ച് ഒക്കെ വേണ്ട ബാഗ് അടുത്ത് നിന്നോടെ നിങ്ങൾ അവൻ നടന്നേ മോനെ നടക്ക് നടന്നേ
This is at the time of fever. So the patient was admitted and he was found to be COVID positive. He was discharged on Diamox 202 and became totally asymptomatic after substance abuse. So this is second case of typical episodic ataxia, which is on reducing Diamox with fever reversal. and he's putting back on Diamos due to no further episodes. He has not come for follow-up for 1 year. That means he's totally asymptomatic. So this is the background in which a suspected episodic attacks in the previous version also. Because it's fluctuating level of fluctuating findings of downwind and fluctuating attacks. With no other findings in the same examination. So any questions?
Sir, how long we should continue this medication?
I think lifelong you have to continue.
Sir, is it possible that we start the patient on Diamox during the periods of episodicity and observe the rest of the days?
No, if you don't keep the patient on Diamox, the patient may get go back into the ataxia again. At any time you can develop.
I know, because sir's case was that he was getting attacks of frequently, I mean infrequently, maybe last for 1 to 4 days, 1 to 3 days like that. So can't we just continue the medication during the periods of episodicity and withhold the rest of the day? I mean, is it possible? I'm just
It's not possible. Without again you develop the ataxia. Once you start the Diamos, it may take some time for that effect to come. It's not immediate.
Okay.
Usually, how long it will last one episode?
That varies from individual. This boy, this episode used to last for 3 to 4 days and then subside. Again, may recur again after 1 to 2 weeks initially before starting treatment. Starting treatment, no attacks at all.
So what is the downbeat nystagmus? What is that?
Pardon? Downbeat.
Nystagmus is downbeat.
Yeah, this is one of the classical thing you find in episodic ataxia. I'll show some slides on that thing, just 2-3 slides. Episodic ataxia is a rare neurological disorder of autosomal dominant inheritance, resulting in dysfunction of the volatile calcium channel. Manifest recurrent disabling attacks of imbalance, but type 1 ataxia can be provoked by physical exertion or emotional stress. See, between the spells, more than 90% of people exhibit central motor, oculomotor disturbance such as gaze holding, websites, headache, smooth pursuit, impaired visual suppression, and especially downbeat nystagmus. That's the most common interictal abnormality this patient can have. Just like our girl, she was never free of downbeat nystagmus all the time. Even she was ataxia is nil, downbeat nystagmus is persistent. When she came to me initially in the first instance, she did not have downbeat nystagmus. So as the time passed on, the downbeat nystagmus became permanent. Then a slow progression of cerebellar signs accompanied by slight atrophy of the midline cerebral structures is commonly observed during the course of the disease. Cerebellar atrophy, especially the anterior vermis, can be detected in MRI, mouse. So that's the story of type 2 episodic ataxia type. Any questions?
Yes, sir. Why can't it be episodic ataxia type 1, sir? There are 8 types of episodic ataxia, no, sir?
Right. There are 6 types of episodic ataxia. The things are all rare. Type 1 and type is most common. So the type 1, there are 2-3 points. The attacks is short duration, 5 minutes. Second, they show myoctonia, myokymia, or myotonia in between. Third, that do not respond to diamonds.
Seizures and also seizures.
Pardon? They can also, but that is not a mandatory thing. That can have seizures also.
So in all cases of episodic ataxia, we can use Diamox.
No,
not in 1, no, sir. Not in 1.
Not in 1. In type, it is type 2, you can use Diamox. Also in type 4 and type 6. So this type 4 types are also theoretical. Because hardly ever we can see seizures. Type 3 and also only one family is described. So for all practical purposes, you should try Diamox if it is a episodic ataxia, because there is a treatable condition. And more is type 2.
Pardon, sir. I didn't.
Pardon?
Sir, I didn't hear what you said just now.
No, the 2 common things are type 1 and type 2. And of the 2, type 2 are common. Okay, that is eminently treatable with the Diamox. The type 1 is uncommon that do not respond to diagnose. Type 1 shows interictal myokymia or neuromyotonia. Whereas type 2 does not show that. You can electrophysiologically you can demonstrate neuromyotonia and myokymia in type 1. And the attacks are shorter duration, lasting for minutes in type 1, whereas it's long duration type plus in our patient.
Okay, sir. Thank you.
So the genetic testing, what tests are sent? It's a panel of them?
The clinical exome panel was done. So specifically mentioning episodic ataxia panel, but that name was taken.
It was not a clinical exome. Whole exome was not done.
Whole exome was not done. But I should have done that.
They say like there may be some genetic heterogeneity and all.
Yeah, perfectly right. See, all things is the cost is concerned.
So.
We usually start at the very beginning, start clinical exome, whole exome, they will not come back to you again. This also after focusing and then arguing, bargaining with the person who does this thing to reduce the short price and authenticate.
The cost is rapidly reducing, sir. No, it is
reducing, but clinical exome still cost 12,000 rupees.
Yeah.
Whole exome will be, I think, 25,000 rupees.
So it is not benign. Actually, it can produce cerebellar atrophy.
Yeah, as progresses, it produces cerebellar. Okay, shall I go to the next case?
Yes, sir.
Yeah. This 65-year-old diabetic lady is a severe pain in the left thigh, radiating along the left leg for the last 1 month. No aggravation with coughing and sneezing. She also noticed severe pain, burning in character over both feet after the angle for the same duration. Aggravated at night. No paresthesia of the feet. So severe pain in the left thigh, radiating on the left leg last 1 month. Then in another type of pain, severe burning pain in both feet up to the ankle. And notice difficulty in walking and difficulty in getting into whether due to the pain or not. We are not sure she's in getting it. So on examination, tone was no. Failures are confined to the lower limb. She was complaining of pain, tenderness in the thigh. But power was normal. Knee extension was normal power. Left also is normal power. Left also is combined. If objection I could overcome and lying down. If extension was normal. Normal power. Knee flexion was normal. Dorsiflexion was 3 to 4 plus. He is weak, I could overcome, but EHL is 0. 0 power of the EHL. Except normal is normal. Invasion was normal. Invasion was weak. Underflexion normal. ETR, both knee jacks were well elicitable. Ankle jacks are 1 plus or 2 plus. Sensations normal. She said no difference. Vibration normally elicited. When she feels vibration normally. SLR was negative. Blood test was negative. There is no clear abductor weakness.
അവിടെ നിന്ന് ഒന്നും സംഭവിക്കില്ല.
There is no heat sagging on the continental side. And she could not stand and walk on toes, I mean heel, you could walk on toes.
നടന്നോ
This is correct.
എത്രത്തോളം സ്പീഡ് നടക്കാവോ അമ്മ നടക്കുക. തിരിച്ചു വാ വേനൊക്കെ സഹിക്കാം, നടക്ക്. സ്പീഡ് നടക്കാം അങ്ങോട്ട്. നടന്നോ? എന്തീ പതുക്കെ നടക്കുന്ന വേന കൊണ്ടാണോ? അങ്ങോട്ട് നടന്നോ?
She walks slow because of the
ഒരു കാര്യം നിൽക്കി.
So findings confined to both the lower limbs. Don't normal in both the lower limb. Our normal for the hip axis, knee extensions, hip extensions, and knee flexors. I could overcome the hip abductors in the supine position. The talent test was negative. EHL 0 power bilaterally. Postprocess inverters weak bilaterally, maybe about 4 plus power, 4 to 4 plus. Under flexion and inverters normal. TTR normal in the upper limbs, lower limbs. Sensations normal all throughout. SLR negative. 8 step age gate. So where is the localization? What is the diagnosis? Any clarification you can ask?
Mononeuritis multiplexer, vasculitic neuropathy.
Okay, vasculitic neuropathy.
Could be Alzheimer's radiculopathy also.
Okay, and anything else?
Because hip abductors also weak.
Hip abduction actually not really weak. Say I could overcome by on lying down, but what happened is that when I examined the Trendelenburg, she could stand without any hip sag. That's what the water video once again. Last one. This is the most sensitive case. And see, she's able to step on standing on the left, right hip goes up. See, right, left hip goes up. Hip abduction is actually weak. But reflexes are all normal. Sensations are also normal. Okay, any other thought? Okay, let us see whether it is self-fair radiculopathy. Very unlikely because one point you have to remember this, monoradiculopathy seldom causes as 8-0 power of any muscle. If you have 0 power of one muscle, it's very unlikely for the routine. Because invariably one muscle is supplied by more than one root. Except certain rare instances like rhomboids, etc. Other muscles supplied by the same root are spared in this patient, as already told. Hip abductors were normal, hip extensions were normal, knee flexors were normal. So it's unlikely for a healthcare routine. Now, it could be a bilateral convolutional pulse palsy. Is there anything odd against this patient? Possible, but absolutely no sensitive pain, even with 0 power of the EHL. Again, is moderate multiplex. But this is the point of simultaneously opening both nerves symmetrically without affecting the other body parts. Certainly, it is odd. So, what will you want one way to do? More possible, it will be a common peroneal palsy only. But there are odd points. What will you like to do now? What message you want?
Nerve condition study, sir.
Okay. MRI, because the radiculopathy part we did MRI first. Because MRI, in fact, the patient came with an MRI. MRI was not. This is axial pattern. There is no any compression in the root. Access was also taken, it's also normal. Contrast, again normal. Now, what are the tests you need?
Now conduction.
Nerve conduction. Okay. So this nerve conduction, you see, the right peroneal amplitude is low, but the tibial distribution amplitude is normal. I suspected that clinically also. The left side also, the amplitude and the conperoneal distribution is this ADB is low amplitude, but the tibial distribution is normal. The APB amplitude is normal. FKV is absent from both peroneal, suspected because it's low amplitude. But sensory potentials are absent both sural and superficial peroneal. So this sensory. So what do you want to do now? Any other investigations you like to do?
NA profile, ESR, HbA1c.
Yes, yeah, those things are all done. That's all.
Upper limb, sir, nerve conduction.
The condition is done now.
Upper limb, sir. Sorry.
Upper limb was not done. There's no complaints or findings in the upper limb. So I did not do the upper limb finding. The lower limb others are all spared.
Serum protein electrophoresis, sir.
It all done normal. It in fact came with this investigations. NA profile, ESR, everything.
HbSAg and HCV, sir.
I don't know. I don't think I must have done.
HD is possible.
Pardon?
HD Hansen's disease.
Hansen is a purely motor involvement here. It's very sensory. Let's be odd for a Hansen disease. Okay, you know what I did? So it's a possibility. How do you treat now? So I gave
So sensory is involved now, sir.
sensory is not involved. I'll tell you. See, these patients' sensory potentials are absent. But clinical examination, normal sensation. So
But clinically was telling burning sensation in the feet.
yeah, clinically she was telling burning sensation in the feet. But only in the feet, that means underneath the feet. And that could suggest that old neuropathy patient had been having. And just got a neuropathy electrophysiologically also. But there was no sensory loss in the distribution of content. See, if you what do you find the findings are confined to the distributed content? HL is weak, rosiprostral vertex are weak. Other muscles are spread. But sensations in that distribution is not affected. Whatever the electrophysiological abnormality was seen was in both the sural and converal. So that importance we cannot give for long taking for the present problem.
So can diabetes cause pure motor neuropathy?
Yes. So let us see what happened. So I gave her IVMP for 5 days with one diagnosis in my mind. And the weakness remarkably improved over the course of time. The pains. She had those but much better than she could not walk. Compared to the previous.
Very good.
What is the diagnosis by which mean? Diabetic emetomy. You know, we may ask why I made the diagnosis. Use later on. What was the clue to suspect diabetic hematopy?
Pains.
Yes, one is got pain in the thigh, even pain in the thigh. That was she was even start examining, she was complaining pain in the thigh. But the deficit is mainly in the convoluted distribution. And no sensory loss. As in usual diabetic hematopy, even with pain and weakness, sensory findings, sensory fibers are not usually affected. You can have only if it is whole rectal plexus may be affected. Only as coin-shaped of sensory loss you can hematopy. So here, absent superficial peroneal snap could be part of her old asymptomatic diabetic neuropathy, since the sural potentials are also lost. If it was not there, if the sural was intact, then CPN, the superficial is affected, then we could say sensory fibers are affected. And more importantly, what is something striking which you observe in this patient? Here EHL was 0, but dose reductions was about 4 to 4 plus. So is it not odd for a common garden variety of common neuronal palsy? Why should that occur? Suggesting that it says there's a partial effect of the nerve. Why should it favor diabetic hematopathy? Because the classical finding in diabetic hematopathy in epilepsy is that it produces sectorial effects on the nerves. The whole nerve is not affected. It's actually it's a microvasculitis. Only portion of the nerve may be affected. So some fibers will be maximally affected, some fibers within the nerve may be spared. So that if you find classical brachial plexus hematopathy also, classical diabetic hematopathy in the thigh also, you find this phenomenon. The same nerve, some muscles may be affected more, some muscles may not conform to a nerve or a root pattern in classical hematopathy. If a adductor may be affected, cortices may not be affected. Similarly, glute may be matching may affected. Other muscles separated by the same nerve may not be same root and may not be affected. So such pattern is common in diabetes. This is also corroborated by this particular finding, the biopsy finding. There is a sectorial effect of the nerve fibers. So just to summarize it, 2-3 words about the diabetic hematopathy. There are 2 types. One is the diabetic hematopathy type 1 and type 2. Type 1 is more common than type 1 in the type 1 diabetes is more common than 1. Type 2 is the one more common than type 2 diabetes. What is the presentation? In the type 1 diabetic hematopathy is bilateral insidious, whereas unilateral acute. The classical one is the one you find in type 2 diabetes. Pain is not present in the type 1 bilateral insidious type. Pain is present in the type 2. Senescence syndrome is not present in the one presents in progressive myopathy or motor weakness. This point we have shown one case before. Whereas sensory symptoms usually present like pain and numbness may present in type 2. Overcome that. I think these are things I will skip. Now, usually they present with weakness, hip flexes, adductors, extensions, and knee flexes, extensions. Angle osteoporosis and brandylosis are affected to a varying degree. Weakness usually encompasses multiple root flexus levels and is rarely isolated to an individual root or a peripheral nerve. Profound atrophy of the thigh and at times distal extremity muscle stimulus. I think that in about 1/3 of the cases, weakness spreads to the proximal arm muscles, attributed to the cervico-brachial radiculopathy. But 10% of the patients develop thoracic radiculopathy. And other presentations are charts in the distal symptoms, only weakness of proximal distal segments. Some days they may be confined only to the distal part. So that is the story of this patient. The root suspect was that the patchy affection of the muscles within the nerve distribution. The pain is present not only in the nerve distribution, in the calf or landing compartment muscle, but also present in the thigh. That is the reason it's not affected. Since the distribution of the nerve is not affected. Any questions?
Sir, do you follow up this IV methylprednisolone with oral steroids for a few weeks?
Which usually I don't know, because most of them they do improve with 3 or 5 injections and stop with that. I do not do long-term steroid.
Okay, thank you.
Sir, in this case, there is a axonopathic change. There is a dropout, like the amplitude is low, but is there any demyelinating changes in the nerve condition study, sir?
No demyelinating, only amplitude was low. Its latency conduction velocity was normal in the contour distribution. Basically, Diabetic ametropy is an axonopathy, not a demonic.
Sir, is it a proximal affection of the nerve or the distal most part of the nerve, sir? In this case?
That one cannot say. Even in the nerve, it only some vesicles are affected, in fact, because it's microvascularitis. See, she has got pain in the thigh, but no weakness. No weakness of the cordyceps. Reflex was normal. So what does it tell you? The pain, there is some reason for the pain in the thigh. That's also due to the nerve affection, microvascular, but it's not severe enough to produce any weakness. So that muscle also is affected. That femoral nerve is also affected. Or that the particular branch of the femoral nerve is also affected by microvascularitis.
Sir, pure axonopathy, how does it respond to steroid if it is a pure axonopathy?
It's an immune-mediated vasculitis. It's actually the pathophysiology of diabetic ametropy. It's a microvasculitis. Vasculitis, the vasa nervorum, vasculitis affecting the vasa nervorum, or the nerves supplying the muscles. That is, it's not conforming to critical nerve distribution.
So is there a role for IVIG?
Yeah, you can definitely. IVIG is always better.
So,
Being a
personal
diabetic,
experience.
yeah, because of the diabetic state, and IVIG is always better.
Sir, have you used and response like same like steroids, or it is less or more effective?
That's in fact, both these treatments, IVIG and steroids, are not what do you call, according to the guidelines. People have tried, found to be effective. If you look at the treatment, they don't say it is. You should try these things. Nobody will say.
But the steroid is supposed to be.
Steroid IVIG is questionable or can be tried. That's all.
Sir, does this patient give any history of wasting of the thigh, sir? Wasting?
Yeah, there's also very prominent in diabetic ametropy. But here there's no wasting because it's an acute presentation. Yeah, and the muscle we expected to be the anti-compartment muscle. If you check, test detect the wasting in the.
Okay. Sir, is there any plexus involvement, sir, in this case?
In fact, these are all called diabetic radiculoplexoneuropathy. That means site of action may be in the root, maybe in the plexus, maybe in the nerves. So that means even though it's called radiculopathy, it's never in the distribution at the root. This patient can have gluteal muscle affection, but other muscles supplied by the gluteal, the roots may be spared. For example, they can have normal dorsiflexion, normal plantar flexion, even hip exercise per week. Can be distorted the radicular. They get involvement of the part of the plexus, part of the roots are affected, and part of the plexus is affected. That's a peculiarity of diabetic ametropy. It does not conform to a particular nerve or a particular root distribution. It's a patchy affection within the muscles, within the nerves of the muscles, supplying the muscles.
What is the chance for recurrence?
Yeah, they can recur again, but usually they are not. They don't recur. I've seen a patient who had recurred again with one leg first, then a contract leg later on. And became bilateral later.
Sir, but pain is need not be there in all cases. No, sir.
Need not be there. In the classical variety, that's a type 2 variety of diabetic ametropy, they present acutely with pain, asymmetrically, with sensory symptoms like pain. Whereas the type 1, which is more common in the type 1 diabetes, they present bilaterally, almost symmetrically, without pain and without any sensory contact. So that variety can be slowly progressive and acute also. But both can respond to steroid motility drugs. And sometimes even with any drug, they improve also over a period of time. Most of the diabetic ametropy, they improve on their own.
It's unrelated to the duration and the control of diabetes.
No, it's unrelated to the duration, and usually it is seen in persons who are cachectic and persons without any reason they die.
So can we consider MNCB, sir? Multifocal motor neuropathic conduction block in this patient because of partial nerve affection.
Here there is no demyelinating pattern or a nerve conduction block as such.
But if we consider proximal conduction block, then nerve conduction tends to axial technique.
If it's a proximal conduction block, yes, but here there is no proximal conduction block. And the amplitude is low. And the axon is affected. If you want to say proximal conduction block, the distal amplitude, the distal stimulation, the amplitude should be normal. Proximal stimulation amplitude should be low. That's not the pattern here. Even on distal stimulation amplitude is low. That shows it is not a proximal conduction. Okay.
Okay, sir. Thank you, sir.
Okay, shall we stop? Or you want one short case also?
Yes, sir. One short case, sir.
One short case. A short case. What is the cochlear movement abnormality? Almost.
उधर देखो इधर देखो
Last to the left side.
उधर देखो इधर देखो उधर देखो इधर देखो इधर इधर उधर इधर
Okay. Let's show one more picture. And brother.
उस तरफ देखो नहीं नहीं उस तरफ देखो हाँ इस तरफ देखो इस तरफ सीधा देखो हाँ उधर देखो इधर सीधा देखो इधर देखो सीधा देखो उधर देखो ठीक है
Okay, what's the diagnosis?
Apraxia.
Okay, my question is not that. Why not lateral gaze palsy?
The head is moving first.
Pardon?
The head is moving first, followed by the eye lag, and his eye blink is there.
Oh, that can occur with lateral gaze palsy also. It's only because the saccades are lost, the VOR is intact. Since the VOR is intact, he has to blink and jerk the head to look at the new target. So in gaze palsy with absent VOR, you are right. But gaze palsy with intact VOR, you get the same thing. So why not lateral gaze palsy?
The Doll's phenomenon, sir. Look for the Doll's phenomenon, Doll's eye phenomenon.
That is only that will be positive in both. Because actually we are not checking the saccade.
Yeah. But in case of oculomotor apraxia, you should expect a full range now in the viewers.
You tell me that VOR will be intact, no?
Yeah, but that will be impaired in case of a lateral rectus palsy.
No, we are not talking about lateral rectus. I'm talking about the lateral gaze palsy.
Gaze palsy, yeah.
Gaze palsy is the one with preserved vestibulo-ocular reflex. Then we have the same thing. They also show the head thrust. But they cannot generate a saccade. Then the same dice will root to the nose, so that you have to jerk the head to move your head eye away from that target.
We can look at the vertical gaze, sir. Vertical Doll's eye.
Yeah, vertical. I don't say not going to help. Vertical saccades. But oculomotor apraxia as well as can be only confined to the horizontal, not to be vertical. Some it may be vertical also, but maybe horizontal like it alone. Apraxia may be only for horizontal saccades. So I'll tell you the reason why. You look at the patient very carefully. I'll show this video once again. Look at it very carefully and look at the eyeball movement.
उस तरफ
Did
देखो.
you see that? Did you see that?
नहीं उस तरफ देखो.
Sir, macrocephalic
Sir,
oscillation, sir.
No,
इस
I'll
तरफ.
show you.
सीधा देखो. सीधा देखो.
Some jerk of the eye.
उधर देखो.
At times,
See that one? I'll show
Yes,
you.
the jerks.
इधर देखो.
Yeah, here got a in between spontaneous saccades, or what we call as a random saccades. See, on voluntary command, this patient oculomotor apraxia, on voluntary command that cannot generate a saccade, but they can have reflexive saccade is intact and random saccades are intact. I'll show the video once again. You find that even between that, when it's asked to move the right and left, sometimes I move spontaneously fast. And then if I spontaneous fast movements you can see, or spontaneous fast saccades you can see. I'll show that once again. Then you will understand.
उस तरफ देखो.
That is a spontaneous saccade.
उस तरफ देखो.
That's a spontaneous saccade in between.
इस तरफ देखो. इस तरफ.
One more repeat.
सीधा देखो.
See that one?
सीधा देखो. उधर देखो.
That one?
इधर सीधा देखो. इधर देखो. सीधा देखो. सीधा देखो. उधर देखो.
Did you understand what I said? If it's a lateral gaze palsy, he cannot make a spontaneous saccade also horizontally. Okay, but he has got a spontaneous horizontal saccade coming between with a normal velocity or higher velocity. That will not occur with the lateral gaze palsy. You got the point. Okay, that's the point. So
Okay, sir.
between these two is one is you can do. You can look for the Aldrich test and you can generate the saccade. That's good enough. Spontaneous saccade is another one. Or random saccades, as you can saccade during, say, searching saccades. When you are during dark, you got a random saccade. These are all preserved in oculomotor apraxias. Only intentionally asked to move, they cannot move the saccade. Other reflexive other saccades will be preserved there, but they are all absent in lateral gaze palsies. Okay.
So what did
Yes,
this
sir.
family have?
Pardon?
What was the cause?
Ataxia telangiectasia, sir. Ataxia telangiectasia, sir.
No. This is only familial oculomotor apraxia. There are no other finding. I normal, nothing. You can have lateral gaze palsy also congenital. You can have like the oculomotor apraxia is also congenital. Usually due to defective function of the parieto-occipital or frontal eyepiece. So, oculomotor apraxia. Okay, shall we stop?
Okay, sir.
Next
Thank you,
week
sir.
there is no. Before the next week there is no class. After that we will resume as usual every week.
Okay, sir. Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir. Good night.
Thank you. Good
Sir,
night.
thank you. Good night, sir.
Good night. Good night.